Good evening.
We're in a new room.
Welcome to the only historically black higher education institution west of Texas, Charles R. Drew University, founded in response to the Watts Uprising of 1965. So, thank you for that additional time. 1721, smallpox. Who am I talking about? An African slave named Onesimus. Hope I got that right. Taught his slave master, Cotton Mather, a very famous person, about variolation to treat or prevent smallpox. Now, we're all healthcare professionals. We've seen smallpox. The photos are some of the most horrendous photos you can see in healthcare. Millions of people died, the indigenous populations of the Western Hemisphere, et cetera, et cetera, et cetera. Smallpox now no longer exist on the earth, we hope, because of vaccination. I could go on and on. I mean, dengue, HPV, HIV, I hope someday soon. But that's what the panel's for. But I will say, as I just mentioned to Ashanti, my daughter just got married in New Orleans this past weekend. And a couple weeks ago, I told her, "Where are you going on your honeymoon? I will not disclose. I am under the penalty of death." But I said, there's a vaccine for chikungunya. Have you all heard of chikungunya? No. So if you can think about where it might be epidemic in the world, you might know where she's going for her honeymoon. And this is a mosquito-borne pathogen that causes significant total body pain that can last for years. Good idea to get vaccinated against it. And sure enough, my daughter, I hope, or maybe it's her mother's, my wife is a physician also, and her husband, a non-medical person, promptly went out to the public health department, thank you, public health department, and now they're vaccinated against chikungunya. Truth be told, life expectancy in this country has probably gone up by 30 or 40 years since 1900. Most of that, and most of the increase in life expectancy around the world, is due to public health measures. And I don't want to overstate the case, but maybe half of that might be due to vaccine programs, and the other half is due to maybe conditions like drinking water improvements. The world would be a very different place without vaccines. And I didn't even mention COVID-19 yet, and I won't, because everyone here at this table is a COVID-19 hero, as is our university. Think of the millions of people who would not be with us today if it wasn't for the mRNA vaccines to prevent COVID-19. So thank you very much. Welcome to Charles R. Drew University of Medicine and Science. I'm looking forward to a great panel.
Thank you, Dr. Carlisle. So my name is Dr. Ashanti Carter, and I serve as the Chief Academic Liaison to blackdoctor.org. It is a digital media company where culture and health connect. So this would not be possible if it were not for one of our sponsors, Moderna. So we are not talking about Moderna products, but because we are living in a society where there's a lot of misinformation, Moderna said, what we want to do is have a 3-city tour where we can bring healthcare providers together to discuss best practices about vaccine confidence. And hence, as a proud alumna of Charles R. Drew University of Medicine and Science, I said, we have to get it popping at CDU. We have to get it popping here. So thank you so much to President Carlisle and also our esteemed panelists for being so gracious and opening up your campus to us. So without further ado, I'm going to pass it over to Dr. Deborah Prothro-Stith, your moderator for the evening. Thank you.
Good evening. Good evening, everyone. What an important topic and what an important set of panelists we have. So I am going to ask them to introduce themselves as they talk about our first topic. And I will introduce that topic as a matter of trust, and a matter of misinformation. Institutions like CDU and those represented by our panelists are responsible for and accountable to our communities around this issue of trust. And I know that each of our panelists takes that very seriously. This institution is literally owned by our community, and we take that very seriously. So the question in that frame of trust and misinformation is, how is it that you, as a representative of the medical profession, but also as a representative of your institution, ensure and protect that notion of trust with the community? What are the things that you do, both as an individual, but also as a reflection of your institution? And we will start with Dr. Davis here, who's representing LA County. And don't forget to really introduce yourself so that we know more about you.
Thank you. Good evening, everyone. So I'm Muntu Davis. I was trained as a family physician. I've been working in public health for almost over 20 years now, and have been in LA County for about 7 years now, a little over 7 years now. And so you can imagine, as a public health department, I had to explain this to my parents. They're like, "Why aren't you seeing patients?" I said, "Well, I have one patient. That one patient is made up of 10 million cells, and I have to figure out in which part of the body disease is happening and what's happening there." And so you can imagine that a lot of things that we do as a public health department are to understand the who, what, where, when, and why of disease. And then once we understand that, to figure out what is it that needs to be put in place in order to control that. And then once we understand that, to figure out who do we need to communicate with. And oftentimes I say we communicate to the 3 Ps. Sometimes I'll make it 4. And that's going to be to providers, who are often going to see people who have these illnesses, and the public, in terms of sometimes through the press, in terms of what they need to understand about what we're seeing. And then also to our policymakers, who may need to do some things in order to change what we're seeing and disrupt whatever that pattern is, whether it's a communicable or infectious disease or a chronic disease. And so as we do this, we try to, at least in particular, I try to make sure that we are giving as much information as we understand for someone to understand the issue just as much as we do. People are very smart. We're in an information technology age where information comes hard and fast and is sometimes accurate and sometimes inaccurate.
Right.
And sometimes it's slanted in some way. And so what we try to do is to make sure that we're providing useful information, not over-explain, and it lets people ask questions, but to try to give the basis of what the issue is and why certain things are being recommended. And so as I look back, when I think about the pandemic, there are some things when I look back now, I say we could have done differently in explaining why things were changing so fast. Mm-hmm. What was the science? What was the information that we used in order to make that change? And you can imagine it was such a stressful time, but you always learn when you look back. And so that's one of the things that, I think we will continue to take forward, is to being accurate about what we're talking about. One of the things that we've learned in terms of vaccines is that, oftentimes people were saying the vaccines, well, I got it and I got sick, or it didn't stop me from getting an infection. And in truth, vaccines reduce your risk. They reduce the chance of you getting an infection. And if you do get infected, they definitely reduce your risk of dying or getting seriously ill from that. But that's not the message that has been said every day in and day out related to vaccines, especially with flu vaccine. Mm-hmm. And so I think we just have to understand that sometimes we have to be honest about what we're talking about in terms of the framing of it. It does prevent. But how does it prevent? In what ways does it prevent? Not that it prevents it from ever happening. There's only 1 or 2 vaccines that can do that. But I think as we talk about things, giving information and also explaining the why is what we need to do more of in order to maintain and build that trust.
So it does get a little tricky. You know, some of what you were talking about is just the balance of how much information gets provided. I think the LA County response to COVID deserves an applause. I do. I know it was tricky, and I know it was difficult, and I know things were moving fast, but I do understand very concretely that as residents of this county, we are healthier and safer because of the response. So thank you for that. We're going to move to Dr. Martinez Hollingsworth from Ultimed, another organization that is very much committed to its relationship with the community. Now, you are involved in research, but I hope with this trust and misinformation, you can share from Ultimed's perspective and as a nurse provider in the past, some of the ways that you and your organization really respond to the public.
Can y'all hear me? All right. Well, thank you so much for having me here. I'm an alumna, so it's always an honor to come back to CDU whenever I can, just reconnect with folks here and meet the next generation, so I always love that. I am Dr. Adrienne Martinez Hollingsworth. I'm a nurse by training. I'm a public health nurse, and when I practice clinically, it's in locked psychiatric settings. So people are always like, how do those things match, right? The PhD and the research and the public health and the psych, and I'm like, it's all the same thing. Right? We're never not doing nutrition. We're never not doing psych. We're never not doing public health. It's framing. And I will say that I've been in academic positions. I've worked in tech companies. I love being at Ultimed. We're the biggest federally qualified health center system in the country. And we are Latino and multi-ethnic serving. So as a kiddo from Northeast LA, first-gen high school grad, I get to work where I grew up with the people I grew up with. So it's really beautiful. And because that's true, to answer the question and sort of to put some framing on it, most recently I was the incident commander at the Eaton wildfire response. So I served at the Pasadena Convention Center for a month, and our biggest challenge there, does anybody want to guess the biggest challenge? It was infections, right? Immediately. And that wasn't what I thought was going to be there, right? I wasn't thinking that we should make sure we have flu vaccines because we can't have the flu going around with 1,600 people in a convention center that was never designed to do this. But actually, COVID, influenza A and B, norovirus, Giardia, a bunch of other stuff, was the biggest challenge that we faced. And our community, by and large, because of the nature of the communities we were serving, looked exactly like our Ultimed population. Latino, African American, older adults, folks who are using safety net services that they couldn't access at the time. So again, it's all sort of the same thing. The framing from an Ultimed perspective, and this is my own analogy, they don't use this, but this is what I think it is. It's like when you're at home and you know that the smoke detector needs a new battery. Now you can ignore it. You can just like go about your business and go like, my husband's gonna do it. I don't wanna be on the ladder, whatever. And it's like, beep, like every once in a while in the background. And you're like doing your stuff, beep, and I can function that way. But it is an uncomfortable tickle at the back of my brain while I'm trying to like chop vegetables. And for our patients, we gotta admit that they are hearing beep because we sterilized people not too long ago, actually, unfortunately, very recently, who were from our communities, right? People weren't given access to even the COVID vaccine at the same rates, depending on where they're from, without serious lobbying, which is why we should also, thank LA County. We got to thank the advocates here at CDU. I was here during COVID, and huge efforts were made to make sure that the folks who needed them got them. But that beep is what you can't get away from when we talk about vaccines, because this is recent history for people, and it is also 1700s history for people. And so from that Ultimed perspective, our goal is to deliver primary care, women's health, dental, behavioral health to the community, but we can do so much more. I'm the director of research in the Institute for Health Equity. I could do a lot, right? We have other departments that do a lot, but if a single patient doesn't show up because they feel like we pushed a vaccine that they don't trust, that they don't understand, that somebody told them is gonna, make them sterile or is gonna give them COVID, and they never come back, we failed. And so all the beautiful icing on the cake of everything that we can do for them comes down to some of these very foundational conversations like vaccines. Because if we can build trust there in established science, clear evidence-based practice, absolutely helpful, then we can do it for some things that are actually a little bit more risky or less palatable, right? You gotta change your diet. I don't wanna hear that from you. But I may listen to you once we have a rapport and trust. So I've talked too long, but I really appreciate being here, and I love the angle on this because I think we know that this works.
Yes.
So what then?
The notion of serious advocacy and serious lobbying is reflected in Dr. Abraham, right there next to you. I remember seeing you on the Rachel Maddow show as you were actively involved in getting vaccines during COVID available to our community. As you introduce yourself and talk a little bit about Kedron and the role that it played, share how you address the misinformation and the need for trust as you took a mobile van around to vaccinate people.
Absolutely. Thank you so much, Dean. I'm going to need a therapy session after this because I'm sure for many of us in the room, all of those memories are coming and flooding back in, and those were some horrific times that we faced as a society and community, but we are here and we have overcome, and I'm very excited about that. My name is Dr. Jerry Abraham, and I'm the Director of Public Health Integration and Street Medicine at Kedron Community Health Center, which is an acute psychiatric hospital, federally qualified health center, and historically black institution in South Los Angeles. We're also one of the teaching hospitals for Charles Drew University, the nation's 4th historically black medical school, and I serve in their departments of psychiatry and family medicine, and very proud of that, and its trainees, its faculty, and all that Drew does for our community. Both institutions born out of that 1965 Watts riots when black and brown people had nowhere to go. And so these really are pillars in our community. So when we talk about trust, that's it right there. You've got two black institutions that really can combat the medical racism, all the discrimination our communities have faced, and they know when a message comes out of Drew or Kedron that I'm gonna probably listen, and we saw a lot of that during COVID-19. I'll just say that it's a scary time, honestly. I'm very worried about where we're headed as a nation with our approach to vaccines. When it comes to trust, we have to trust our health professionals, our doctors, our nurses, our scientists. But now I'm scared that they're not even getting the education they need, and that scientists are not getting the support they need in order to develop, innovate, so that we can have vaccines for HIV one day, for example. These are all very scary realities. And so first and foremost, we need all health professionals to really step up right now more than ever. And we really need to recommend strongly and urge our patients to get fully vaccinated and to follow the recommendations, to follow the science, to follow the experts. And unfortunately, right now, that may not be Washington. It may not be our health secretary. It may not be our CDC, but it might be our California Department of Public Health. It might be our county health officer. It is the Western Alliance of states that have now put forward their recommendations. And it's also our American Academy of Pediatrics and our American Academy of Family Physicians that have their strong recommendations, and our obstetricians and gynecologists that are helping make sure that we take care of pregnant persons well. So right now, more than ever, do you know where to go as the prescriber for those recommendations? Are you taking those recommendations seriously and recommending them to the patient and the family in front of you? We got to definitely think about that one for sure. The patients, one of the issues, and I'm so excited to be sitting here with Dr. Davis, because we were kind of on different sides of a lot of these struggles. I picked up the phone on Christmas Eve and said, where are our vaccines? I was very worried that South LA and people that were on the front lines, working in grocery stores, driving our buses, essential workers, they had nowhere to go. Meanwhile, we saw plenty of folks jump the line, digital demons, this, that, stealing people's shot. And so we knew we needed to change the way we did it. We knew that a lot of patients don't have cars to drive to Dodgers, so we needed to be able to walk up. We really had to rethink a lot of that. It was risk. It definitely means we pushed the envelope, and that's where I did feel like, I'm scared I'm gonna get in trouble by them, but somebody had to say it and somebody had to do it, and that's how we ended up with over 400,000 doses in the arms of patients who needed it most, Black and brown Angelenos. In fact, many wealthy white West Siders found their way to Kedron,
Right.
probably for the very first time, for a field trip or a tour.
That's true.
But we told them, hold on, we'll wait your turn, because we set it up just like LAX, like a boarding gate at the airport. And we knew that seniors, those with serious medical conditions, health professionals, those from our zip codes, those that were working, get priority. You want to wait? That's fine. And we had people camp outside. And we also said, you want to volunteer? You want to help me find 10 people? We'll get you a vaccine. But go outside and bring people, because they were scared. Why would I listen? And so lastly, I'll just say, trust. What we said was, look, I'm rolling up my sleeve. All these health professionals lining up around the block for these white folks coming from the West Side. You think that we're trying to drug you? You think this is the mark of the beast or 5G technology? These are life-saving essential medicines, then they're for you and me.
Right.
So please come and take them. And that was a very important message. And we have a lot of work to do, because I'm worried we're unlearning a lot of the messages that we learned during COVID-19. While it was yesterday, it feels like it was ages ago. And unfortunately, with this administration, I feel like we're turning back the dial on health and people decades.
Thank you. Yes, yes. As we really think about messaging and some of the mistakes that public health made, that we made during COVID, I worry that our health education, science education in the public schools, and not just in the public schools, actually, that we're not teaching in a way that allows a public to be literate around health and taking care of their bodies. So messaging in that requires some skill. And you just got to a little bit, Dr. Abraham, I mean, I do call you Jerry, but I'm going to call you Dr. Abraham because we're on the panel, of the way you use even the presence of people from the West Side as a way of saying this is something good for us. I want each of you to really reflect on an experience with a patient or an institution where you struggled with messaging and the education that was required in that setting to move toward getting a patient vaccinated or getting policy change. So think of an example that you can share with us that really is along those lines. And Dr. Martinez Hollingsworth, we're going to start with you on that one.
Whew, I got something that I remember at the time was the biggest challenge in my career to that point. So recently, I was an associate dean at a large university in the Bay Area. And we had it was a health sciences university. I was in the Department of Nursing, and we had 4 different training sites. We were the biggest producer of nurses in the state of California across 11 different programs from accelerated bachelor's through DNP. And we were, of course, in my mind, requiring that our employees, but also students, got the flu vaccine and got the COVID vaccine. You're going to come to school, I need you to do those 2 things, because we know that you're dealing with vulnerable patients. Actually all of our sites were based in communities where we knew there was higher risk, they're in Oakland, they're in rural areas in Northern California, I need you to be vaccinated. And we had a large number of our students who were refusing or getting exemptions. And these were not medical exemptions. It would be lovely if they were, but they were not. They were sort of philosophical pushback on the idea of being told that they needed to get a vaccine. And so at the time, I had a lot of directors come to me and say, I don't think this is something I'm emotionally, spiritually, like ready to weather. It's challenging teaching students nowadays. And I know that if I push this too hard, I'm gonna get terrible reviews. I'm gonna have, I'm gonna be in front of the ethics committee of the university. I'm gonna have all this stuff come against me. And so we worked through it. Turned out to be, you wanna guess what percent of our student body was not vaccinated and gleefully, joyfully not vaccinated? Health Sciences University. 30%.
Whoa.
Were requesting exemptions. And that was just so deeply disillusioning to me. Because healthcare is a passion and a calling, and we feel it deeply, but it's a science, baby. And if you don't believe in the science of it, you may be in the wrong program. Otherwise, why did we do all those prereqs? Did we not suffer through OCHEM? What are you doing here if you don't believe this is a science?
Right.
And so I said, I think there are established national guidelines for medical exemptions, and I think we go with that, and everything else, no.
That's right.
If they want to delay graduation because they can't go to clinical without it, then that's what happens. And I really want to make sure that they're not all going to the same person that is giving them an exemption. So I really want there to be an audit of these exemptions. And I do remember the dean at the time, who I respected tremendously, say, "Are you sure?" And I was like, I mean, if this is the hill, this is the hill. Right? Because you carry that messaging into every single clinical interaction you have from then on. You don't believe in the science, you don't believe in what we're doing, I don't want you seeing patient one. And I know that's not popular, but it really felt so foundationally questionable in this industry to allow it to go unchallenged. But I will say, I thought I might lose my job over it. I thought I might be in front of the review. I knew there was risk, but it is so fundamental to what we train our students. It's just really shocking that that's an experience I can relate right now.
That number, 30%, is something that was also reported on the news during the pandemic, and it really did cause the public to think, well, if the nurse isn't going to get it, if that emergency room doctor isn't going to get it, I'm not sure that I'm going to take the vaccine. And we had to come up against a lot of that. Dr. Davis, I know the county had some of the messaging and education issues to address.
Yeah.
And by the way, I think that I'm sure your team was preparing Dr. Freire. I think she did a remarkable job in those press conferences, doing the education and letting us know. But tell us a little bit about the struggle behind and some of those messaging issues.
Well, what's interesting is some of the same experiences Dr. Abram mentioned, we saw as well. Some of the same things, it's like I think one of the things that we had to realize during this, and I think we have to realize this every day, is I don't think everyone expects us to be perfect. But they do expect us to explain stuff in a way that they can understand and answer their questions. So part of building trust is communication. I may tell you that this is what's recommended. You may say, I don't want it. I may ask you, why don't you want it? I'm not pushing it, but help me understand. You tell me something else, I'll give you some other information, and at some point, you'll make a decision one way or another. And I'll respect you whichever way you want to make that decision. But I think what happened in this was there wasn't the science-based discussion. And it became I would say more of an individual and somewhat political discussion. It was really about, you're not going to make me do something. I should have a choice to not do this, even though we're in an emergency. And that is very different from the science. And so once you get into that realm, and I think that's what a lot of healthcare providers were saying, was like, I don't want to take this because I don't want it, for whatever those reasons were. Not so much on the science, but because, I can tell you which groups would I can tell you which groups really wanted to get the vaccine and then was available, didn't get it. Because they wanted to have the choice. They wanted to have that prioritization. They wanted to be in that special group that got it first. That's why people showed up at their clinic. That's why people showed up at our forum clinic. But we had to adjust in those processes. We were listening to people. We were hearing from community health workers who were in the community, hearing from people. We were hearing what they were saying. We were saying, okay, let's figure out how we talk about this. And so we would make this dialogue that we put on paper to give to people who were trusted in the community in order to say that and then hear what we get back. And so we had this dynamic dialogue that was a few people down. Hopefully it wasn't like the cans and it didn't get messed up, you know, when you
Right,
person
right,
to person.
the telephone game.
Telephone game, yeah. But we had to make adjustments. And that's what we did constantly. We'd hear something, we'd see something, we had a clinic, it was all drive up. We were like, okay, people are walking up, we gotta figure out walk up, let's change, let's figure out walk up. We gotta do this, we gotta do that. And so we made adjustments along the way. And I think that's what's important to realize in some of this. And sometimes it isn't the science. It isn't the science at all. It's really about choice. And that's what a lot of the pandemic ended up being. You're taking away a choice that I need, that I want to do. Not worrying about anybody else. Sometimes not worrying about the people closest to them, but it was about choice. And that became the political nature of it, choice. They're taking away your choice. They're taking away your choice to open up your business. They're taking away your choice to go and eat in a restaurant. They're taking away your choice to go to the club. They're taking away your choice because they're gonna make you do a vaccine if you wanna go to the club. And so it became that. And that's not science. That is just interpersonal. You can't make me, which I understand. I completely understand. But it wasn't what we needed and wasn't what was best for us as a community, as a society, as a county. And so that's where sometimes when you differ, you get off the science, you have to go to that other side and have that other discussion so you can get back to the science. But sometimes it just takes time. And so we recognize that, we understood that, we just tried to keep updating our messages in order to make sure that we were responding to what we heard.
So I have to say, I was very thankful that the county was requiring vaccinations for going into restaurants and other, because I know some people who only got vaccinated to play golf or to go to the restaurant or go to the club.
Yep.
So, you know, it was a different role that you were playing, but that messaging and education piece, I really appreciate that sensitivity to. There is some risk research that suggests that people will inflict on themselves much higher risk than they will allow you to inflict on them. So smokers who get upset about an environmental pollution or others, you can think of those ways, and it's pretty clear that if I'm doing it to myself, I have a lot more tolerance for that risk than if you are imposing it on me. And so that's a kind of flip side of what we experienced. Before we go to Dr. Abram, it looks like
I
you
was just going to say, if I had $1, even a dime, for every heavily tattooed person that didn't want a blood draw because they're scared of needles, that's exactly what it's making me think.
Yeah, that's interesting.
Okay, I'll do a quarter for every professional athlete with tattoos that was curled up like a ball in the back of their Escalade and barely let us poke them. And it's like, what, how? You know, so we see the needle phobia is very real. Trypanophobia, look it up, and we had to deal with all those things. So I'll pick up where Dr. Davis left off, honestly. So our story, we had mentioned Christmas Eve, and then working very closely with y'all's team. By New Year's Eve, we had our first 50 doses, and then the next day 100, the next day 200, and then that's how it all exploded. But those lines, we were vaccinating 3,000 to 5,000 at the height of those programs. By March, those lines started thinning out. So we got those eager beavers in and out pretty quickly. And we knew if we didn't figure out how to get it to everybody else and change our strategies, which is why we immediately switched to the mobile vaccine program. And so can we meet people where they are, where they live, work, worship, play, where they go to school? Let's not leave the homebound or the homeless behind, right? And so those were the things that we started doing by taking a fleet of vehicles out into the community. And so we did. We went to those parts of town that we do believe are underserved. And there are lots of reasons, structural issues, systemic issues, and we should all be working towards those. Those are where the policy matters and our advocacy counts. But we also, in those moments, needed to act and do something too. And so we did. We went to South LA. We learned a lot from our patients and the community too. In some ways, thank God we have white coats. We were in places with Bloods, Crips. We never knew were we going to wear the right or wrong color. We definitely got jumped here and there. We were definitely nervous. There were people that would be high or this or that we'd encounter on the street. So, there was a little bit of, it was exciting, but there was a little fear in all of us too. And so one particular vignette I remember was definitely a young gentleman who's clearly, some may call gangbanger, let's say involved in, activities or clubs or circles, right? As I always remind folks, that's your protection, that's your crew, that might be your family. So we see it one way, it might be a very different reality, or you may not have a choice. You either play nice or you're gonna get in trouble, right? So this young gentleman definitely came up. He definitely was pissed off that we brought those to his community here in South LA, in Watts. He definitely wanted us to take our van and go away. And he had just walked out the liquor store too. And he had that very, he was worked up. He had that stance. He was ready to fight. And I remember, I was like, we ain't trying to do anything to you. And we're not gonna do anything that you don't want, that's for sure. Because I do believe in people's agency and autonomy and respecting them. And that's one of our medical ethics for sure. But that particular gentleman, we kept crossing paths with over the next several weeks and months. Individuals like him, he took about 14 encounters, and he was, in the meanwhile, bringing up family members and this and that. So it's like, okay, so you're really pissed that we're here, but you did bring grandma or auntie with you the next few times, Finally, one day he said, I think I'm ready. So if we're not patient, if we don't meet people where they are, that's not just physical, that is spiritual, mental, all of those things. He would never have gotten vaccinated. And he began to trust us. So in those encounters, what we definitely do, we stare people in the face and we say, we recognize that there is a true history of medical racism in this country, and that men were denied treatment to syphilis in those Tuskegee trials, and that Henrietta Lacks were used and abused and no credit given or compensation, that black patients are denied pain meds in hospitals, and that black mamas die, even if they're rich, delivering a baby in this country today. And then we said, this is not that. These are those life-saving essential medicines that you need. And then we go from there. And then we give them space, and we let them choose. And I said it multiple times, including to him, I trust you to make the right decision for yourself and your community. And people did. People wanted to keep their families safe. That's that choice thing you mentioned. We give them the agency, the power, the information. They will choose to do the right thing. And we saw plenty of people, but give them the time to get there. That was very important. I'll say that we had mantras. We partnered with the CDU mobile team as well during that time. And we would say engage, educate, vaccinate. And then one of the biggest partners were the patients themselves. We activated them. They became the people who went out there and told their family, yeah, we're going, let's get it done. When we think of women in our families, black women in our black families, right? They are sometimes the only people that some people in the family will listen to, including black men. We think about that when it comes to hypertension. We see how important women play a role, your grandma, your spouse, your daughter. That might be the message. So to your point, the science, the communication, it's not just that. It's all these other pieces of a puzzle. It's recognizing the history and the past, the real fears. And the last thing I'll just say is from the very beginning, we really challenged the media and the public every time they tried to make it sound like Black and Latino people didn't want these vaccines.
Right.
They kept talking about refusal and hesitancy. And it was like, excuse me, you mean where are our vaccines? It was more about where's the access, you know, and why are we not trying to meet people where they are? And that was not the question, for better or worse, from the mainstream. And honestly, you know, I hate to say it that way, but the white media. So we really did have a lot of trusted messengers, including Black and Latino media outlets, leaders of the Black church, for example, priests in the Catholic community, employers, principals, law enforcement, you name it, people stepped up, got vaccinated publicly, and that sent a resounding message to their community. So lesson learned, doesn't always, it's not just the doctor or the nurse that's gonna move the dial, it might just be your pastor.
Yep. It's interesting. I think of medicine as the practice of science and the art of medicine, communication, being able. Public health really is sort of the science plus the politics or the communication with the community. And I think some of the lessons we learned in COVID or relearned, because people knew some of it, but you know, in an emergency and when you're trying to get things done, I think we relearned some of those messages. In the case of COVID, the political side of the equation, science and politics, got very confusing for people. And I don't think public health was used to or ready for a political side that wasn't interested in the science, wasn't respecting the science. And at the federal level, the same person who said maybe we ought to inject bleach also was the person who said we're going to get that vaccine out and we're going to get quickly. And I think confusion was part of what we were up against in a way that I'm not sure we understood from the public health perspective how to really operate when the science was just sidelined in many situations. You talked about the current climate and the future. So my next question for you, taking the lessons that we've learned, how are we going to operate in this current climate to ensure the health of our communities? How are we going to deal with confusion, with misdirected misinformation, both as providers and as institutions?
Before we go
What you
there,
gonna
Dean,
do?
I had a comment on what you had just mentioned. It was scary for us as scientists and health professionals too. Not only were we losing each other, we saw how many health professionals get sick and or die. This was a tough time. The burnout was real. We saw suicide amongst health professionals, but even the science was scary for us, right? What is a nanoparticle?
Right.
Now it's like, you know, kitchen table conversation, but back then an mRNA vaccine was frightening.
oh,
Right?
yes.
So these kinds of things, and then we're accelerating a process through the Food and Drug Administration. And we're asking our
that's
advisory
scary.
committee on immunization practices at the CDC to let's go with this. We know that we've altered the process. We are doing it in a way so that we can get the approval and move forward, but we're not circumventing the science or the clinical trials. That's complicated to communicate to anyone,
Right.
including health professionals. So we were all a little bit like, I don't know what is exactly happening, but I'm supposed to just slap a smile on and be like, get one.
Right,
you know?
right,
It
right.
was a frightening time. So we do need to work on that. And when it comes to trust, I think important to mention the National Academy of Medicine is looking at this very carefully. There's a whole collaborative now on trust because the public is not trusting science and medicine. And that's a real problem for America moving forward. The United States Pharmacopeia is very worried because people are not taking their medications. They are afraid that we're trying to poison them or that doctors are getting paid to vaccinate you. These conflicts of interest. And the Union of Concerned Scientists, there's a whole movement around trust and how we regained that as health professionals. The last thing I'll just mention was blackdoctor.org. I mean, that's exactly part of it too. Are we empowering our workforce? Are we training them well? Are we helping the community connect and find them? And so that's why resources like that are clearly very important. The last thing I'll just mention is we learned a lot from our past. When we think about our ancestors and our history, Drew played a very important role during the HIV epidemic. And I think Professor Cynthia Davis and her mobile HIV testing and her mobile HIV care, going out into the community. I mean, what I did was really replicating what she did, right? We're building on the shoulders of the giants that are still amongst us, and definitely the ones that came and have gone. But we really need to bring those lessons back sooner. Now we've got HIV, now we got COVID. So to your question, I feel like we're already forgetting all of this. And we are going to face, I'm sure, some future challenge. That's inevitable. We are going to be less prepared than we ought to be. The playbooks have been thrown out or lit on fire. So we are going to have to think creatively. And I hate to sound like this, but now I sound like someone from the South. You know, states' rights versus federalism. Well, by God, then let us Californians do what we need to do to protect the state. And if that means I can't know for sure that the CDC, the FDA, the NIH, and our HHS is where I go for that information, then I might have to start looking to Sacramento or to Dr. Davis for that information. And so the paradigm is definitely changing, and now sometimes I feel like we're on the other side of things a little bit, where I'm like, okay, maybe I don't trust the federal government as much on these things.
Gets confusing, it does.
So, you know, I want to say that right now we have to recognize the difference between authority and expertise.
Can you say that again, please? Because that,
We have
you
to
all hear this?
recognize the difference between authority and expertise. So we have people who are in authority who are giving recommendations and advice with no expertise. And in some instances, they are looking, after they say something, they say, am I right? Is that accurate? Bleach. That'll work, won't it? That'll work, won't it? You know, and so I think that that's the thing that we have to understand. Now, how you differentiate those, in this time where we are going to run into some challenges, we have to activate, educate, and motivate more people than just ourselves, more people than just our institutions. We recognize that some of the things that we're seeing are related to policies and politics, and that has to change. And some of the things that we're anticipating, there will be some things that will change, and many of us, in terms of funding and what's required with that funding in order to push certain ideologies or certain policies or certain politics. And we have to, and we're in this process right now as a department, saying, what is our purpose and our role? What were we created to do? Now, what can we do? What will we do? What do we need to push to be able to do in order to fulfill that role? And so that's one of the things that we're talking about even as this moment, as we are anticipating future budget cuts, focusing in on what is our core function. Let's revisit that. Now, what things do we need to make sure that we maintain as we look at the potential for funding to be much less than what it was? Now, our health department is $1.8 billion.
that's big.
It's big. And I will say that over 70% of it is state and federal dollars.
So,
Over 70% of it is not something we can move around. We cannot shift. So we have to be very real about motivating others who can influence those who have the power, the authority to change, and allow for that flexibility, allow for science to be independent without political influence. And as you look at what's happening with the CDC, it's being undermined. If you look at the new priorities that came out, they're not science-based on some of those. And so that further undermines it. And then that same document, they're talking about building trust. I'm not sure how you do that in that fashion. But I think as is what's happening is states are saying, look, that's not going to work for us. Our state in particular said, you know what, we're passing legislation. We're passing legislation that, yes, we will take the baseline of what ACIP or the CDC says, but we can add on to it if we think it's going to be more protective for our community. And they've done just that. And smartly, they put it into a bill that once it passed, it was immediately in effect. So COVID vaccinations, you want it, you can go get it. Look at the recommendations from CDPH. They aligned with Washington, Oregon, Hawaii, all together. Other states are thinking about doing the same thing. They look at the professional organizations who also use science and rigor to go through and say, what's the evidence? Is this evidence high quality or low quality? What's the risk? Is this going to be a benefit? What risks are there going to be to that? Those are two separate processes that, honestly, the ACIP adopted in 2010. When they got rid of all the members and the new members that were on there, they didn't use those.
How do we reach people not in places where they have a substitute for a trustworthy federal or state or even county system? What is our responsibility? How do we?
Well, I think whatever we put out, we should be able to stand behind, and we should be able to explain why. We learned that very strongly during the pandemic. We're learning it even stronger now. And understand that people are looking even here to see what's happening. I can say that our website, even during the pandemic, it got way more hits than what we would expect it here. It got hits from all over the country to see what we were doing here. And so I think it's going to be the same thing in terms of recommendations. What is California doing? It's one of the largest states. And so I think as we talk about things, and even as an organization, as CDU does stuff, it's like, as Kedron does stuff, put it out there, can you explain it? If you can explain it, somebody will take it.
Yeah.
You know, I mean, I can count how many times we've been in meetings where somebody said something, nobody addressed it, nobody talked about it, and then somebody else said it and they loved it. You know what I mean? But it's just a question of that first person actually planted that seed, in my opinion. You know, and so we have to be able to say stuff and be honest about it, be able to back that and explain why we're doing that. And I think the more that we can say that to and explain that to, I think more people will take it and run with it.
I do think we have a responsibility beyond California. It's a small world.
Yeah.
It's a very, very small world.
And infections don't see
yeah.
borders, you know?
Yeah, we
What
do.
happens in Tijuana, we see in LA.
So,
Can I just quickly on Dr. Davis's point, you know, multi-sectoral is very important, right? Because we saw industry stepping up. It's how Moderna, Pfizer, Johnson & Johnson,
Right,
everybody
right,
stepped up.
right.
But we clearly had to work with the Department of Defense on accelerating production. There were several levers that we had to pull. In our county, there were several things that I know the leaders at our county health department couldn't say. So we were having conversations every day during that time.
Sure were.
We were up late at night trying to figure out that next, how do we reshift this prioritization? And there were times when it was like, I can't say that publicly, but you know, if you happen to say that on Spectrum News, you know, or even like next time you see the supervisors, you know, because it is that partnership. Barbara Freire can't always say the things that she needs to or wants to. That's why we all have to come together. And there are definitely things that, because of conflicts of interest, if you're a for-profit or, you know, whatever conflict you've got coming, there are reasons why we have to check the private sector too. So it really is this yin-yang balance between all the sectors. And that got us through this pandemic. And I think that's part of the secret sauce to the future one.
yeah. Dr. Martinez, I suspect you have some thoughts to share about this notion.
I
of
do.
How we operate in this context.
Yeah, and before I give you a little bit of like super nerdy, wonky, right straight off the presses hope, because I actually do have something cool to share as long as we don't share it too widely until it gets published. But before that happens, there aren't enough of us, which is awful and also kind of cool. Because if I am in Chicago or and follow me on LinkedIn, I'm all over the place, right? All over the country, meeting with different people. There ain't that many Latina nurses. There just aren't. I wish there were, but there's not. There's not that many Latino physicians. There aren't that many Black doctors. There just aren't that many of us, which means we're a small network and we can go pretty far with our social relationships. right before we started this, I took a selfie and sent it to colleagues we have in common because unfortunately we're small enough that we all know each other. So those conversations that I will have with you over margaritas are different than what I'm going to publish and what I'm going to say when I'm in front of a formal body. And I think we lean into those because maybe this pushes you in a direction that encourages you to be more bold and brave, to have those conversations, maybe socially, maybe away from your organization, maybe over dinner, but really start a movement that is word of mouth, like, you know me, we just went out and had, what, right? We need to have those kinds of conversations, not just to keep people accountable to what we agreed to, but also to give each other hope. There is a resistance.
There is a resistance.
There's a resistance, and it looks a lot of different ways, and sometimes it's coffee, right? But we have to keep that messaging going. So now for the super nerdy, very nerdy, get ready. So people, I'm sure, are familiar with Bronfenbrenner's socio-ecological model, right? It's a bunch of nested circles that's used in public health that's about how you have the individual and they are sort of surrounded by their immediate family, and that family in turn is surrounded by their local community, can be the parish, can be just like their neighborhood. Then right outside that, you've got, you know, their regional, like the city, and you've got public policy, you've got the, you know, the nation, the world. And so we are all living at these different levels simultaneously with different levels of influence. The latest research that's out of multiple places that started in Puerto Rico is going to be published by Dr. Martin. We're working on building out the model, actually shows, well, let me just ask you, where do you think your provider falls in those circles? Where do we put them normally? Nobody's been doing call and response. This whole time I've been yelling out, so I should stop doing that. Most people would put them in community, right? Or in like a systems place. But study after study after study for decades puts them in the family unit.
Wow.
At least in Latino communities and multi-ethnic communities, that's a family member that is often handed down over generations. This was mom's doctor, now it's gonna be my doctor, now it's gonna be my kid's doctor. Oh, now that they get out of pediatrics, they go to that person. I stay in contact with this person, I'll drive a few extra miles for this person. This deep enmeshment that the patients, especially in communities of color, have with their provider means you are family. And if that socio-ecological model gets updated from a more communal culture, familismo perspective, how much agency do we have as individuals in every conversation we have with patients who not only trust us, but love us as family?
Yeah.
I'm getting all emotional about it, but honestly, it is the explanatory mechanism behind so many reasons certain studies have come out the way they have. We just haven't really understood it because we are ourselves a profession, and we've had to go to school for so many years. But that's not me in the room. In the room, I'm Adrienne, and I'm like, Senora Sanchez, what happened? How did it go with your aunt? Oh my gosh, tell me everything. And then I'm like, oh, I only got 15 minutes. It's okay. How's your foot, right? We are maintaining these relationships, and that is trust in the most foundational way. And so if we can see ourselves outside and inside of the white coat, I think we have a chance, not just with the patients, but with each other.
So that's a message for blackdoctor.org as we think about it. And I have one last question, and then we will give you the opportunity to ask questions. This is about training future nurses, future doctors, future PAs to understand that point and to really be comfortable with that. Now you're talking to the president of a university, the dean of a medical school. What do we need to do to train our doctors and our nurses in that very special space? Because it is a very special space. It's almost a sacred space.
Yeah.
I hadn't heard that research, but that's very interesting, and it certainly rings true to my time as a provider. How do we train on that?
So I'm gonna go back to an experience and give this experience because it shaped me into the doctor that I became. Before I got into medicine, I wasn't sure that I wanted to be a doctor. And I was a Spanish major, go figure, you wouldn't expect it, Spanish literature. And I went to volunteer at Olive View Medical Center translating for doctors, Spanish to English, and back between patients. Because I wanted to see what the interactions were, I wanted to check it out. And so I would literally translate what the doctor said to the patient. And then after the doctor left, I'd say to the patient, "Did you understand that?" And they'd say no. And then I'd say, "Okay, well, here's what it is." And so we would talk in just regular language. And I think that's something that we have to learn as professionals, even in our organization as public health department. We can talk in our own language, but it doesn't often translate in the same way to the people we're talking to. So one of the things that I learned in that was really that I have to talk to the patient and with the patient. I'm not preaching to them. This is a dialogue. They are making decisions. I can give advice. They are going to make decisions. I need to answer some questions in order for them to make their best decision, and that's my role. My role is to help you make the best possible decision for your health. You may choose to do something different. Again, I will respect that. But as long as you understand and you have the information to make that decision, that's fine. And so in that translation, it was really that I had to talk to people at their level. I had to explain things in a way that they understood, not the way my training taught me. And so I think that's one of the most important things is part of that art of medicine is having a good and strong relationship, an honest and communicating relationship with that patient and their family.
That's right. The word significant comes to mind. When I was Commissioner of Public Health, we were working with the community, and one of the public health leaders in the department wanted to say, "This is not significant." And we had a long discussion about the word significant, because the word significant to her meant statistically significant. To that community, it meant you are minimizing our problem. You are saying it doesn't matter, and we're saying we have cancer rates in this community that are scaring us. So it's an interesting, thing to learn, to be able to have those conversations that are really very important conversations, and training our students.
Yeah, so the only research I've ever done that's sort of gone viral is called the burnout dyad. And I developed it when I was at Stanford with a lab there that was called Everyone Included, which matched us up with patients and really had sort of, equipoise wrapped around the conversations. But what it fundamentally did was challenge what I think is this false dichotomy of patients and providers, because that's how we're trained. Patients and providers, us and them, the doctors, the patients, all that stuff. And the reason I think it's a false dichotomy is because literally we are all just patients.
And when we
some
become
of us,
one, we really are.
some of us happen to also provide care.
Right.
Not all of us, but we're all patients. And when we're talking about the deep, rich relationships in communities or with individuals that we're providing care for, there's a lot of personal, emotional, physical, psychic risk involved. You're asking a lot. And I think the reason I love CDU, the reason I come back to CDU whenever I'm asked, is that I've been at a lot of, really lofty university spaces. And it wasn't until I came here that I felt seen as an individual. That people actually asked me what my life was like. Dr. Carlisle one time out on the lawn was like, "You got that stats thing coming up, right?" And I'm like, "I do," right? I remember feeling seen as a person and acknowledged for how hard this is. We spend decades in school.
That's true.
Sacrificing all these things around our communal cultures that are deeply meaningful and a literal sacrifice, right?
Yes.
to do this. And that needs to be acknowledged no matter where you are. It needs to have investment in wellness. It needs to support people's, spiritual pursuits. It needs to acknowledge that you need to be physically healthy. You need to eat right, right? Like all of that other stuff to prepare you to turn down the patient sometimes, even though they never go away.
Yeah.
And you turn down the patient part of you. So you can be the provider. Because otherwise, we're racking up harm points in every single one of these things we go through. The pandemic, and then where I am, we had floods, and then we had the wildfires, and then we had ice raids in our clinics. Man, it is like thing after thing after thing after thing after thing. It's not about, is this stuff the right thing to do? Do we have the policies in response? It is, are you able to sustain this as a marathon career? And so when we talk about preparing the next generation, acknowledging the beep, right? Acknowledging they're walking into that space and people already are going to maybe not trust you, but also acknowledging that you may not trust you. And this is a huge burden, and we care about you. And we're here now. We're here for the next 20 years, which is why I always say I come back to Drew because Drew's home. And when I need to, I come back for this nourishment and reminder of the who I am and the people that care about me. So, getting all emotional.
We're all patients. Yes.
Can I just add a little bit to that? I really appreciate that. Dr. Martinez Hollingsworth. A lot of food for thought there, isn't there?
Yes.
I'm learning a lot. Yeah, I probably should pay you tuition dollars for the education I'm getting tonight.
Or margarita.
We'll collect it.
On that note, I don't have the answer to your question, Dean, but I am very concerned about the Supreme Court decision that overturned affirmative action, right? So I'm concerned about access for Black and brown students to medical schools and other health institutions. I think when we think of the caps on student loans that young folks are facing today, you're only going to be able to do this if you come from a wealthy family.
Right.
This is all going backwards, right? Because the truth is we should have a health professional in every one of our families. We should be encouraging all of our kids into science and math and, we call it medicine, but we really need to call it health because we are so siloed. There is such a divorce between public health and medicine in this country that is not true in many other countries around the world. And then even within the healthcare delivery space, there are these firewalls between nurses and doctors and all these things that are, it's like we lost sight that it was about this continuum known as health that really revolves much higher than treating a patient or, bedside nursing or epidemiology, right? And so I feel like how do you instill that in people that we're at a Charles Drew University of Health, where we all are learning to pursue health for ourselves as individuals, because that's a philosophical pursuit. I feel like because of medicine, I have learned literally more of what is inside me, while we also ask that existential question, who am I? But there's a lot of opportunity if we can get everyone into health education, wherever that is, elementary, middle, high school, beyond. And then from there, I hope everyone chooses to become a health professional or should at least be engaged as much to be a promotor, community health worker. We should all have one of these in all of our families, and then we'll all be better off.
We should all be literate around health and our bodies. And we're a bit of a ways away from that as a society. We're all patients. All right, questions from you and any thoughts that you want to share?
Hi, great presentations by all of you guys. Continuing on this theme of politics, unfortunately, which is the big elephant out of the closet, I just want to get each of your opinions on what our historic NMA did this week in asking for them to get rid of our secretary. What is your opinion politically in terms of what you know, health?
ducking for cover. I'm going to hide under the table. But we're trying. Oh, goodness. That's a tough one. I
It
will
is a
just say
tough
really
one.
quickly, I am very proud of the National Medical Association
Yes.
for stepping up, being
Yes.
brave, being bold, and saying something that other folks just aren't brave enough to say. And that is something that the AMA has failed us in doing so. And so I hope that others follow the NMA's leadership in this way. And this is not the health secretary that our nation needs, and that's the reality.
Any other takers on that? Don't get in trouble.
That's right. Well, I think what I will say is, again, sort of going back to, I think part of what we have to do is go back to what does it mean when we say scientific rigor in a way that's understandable for people. I think, the fact that, I think ACIP had a discussion about, an increase in febrile seizures after getting the MMRV vaccine, between the ages of 12 and 15 months, and that increased risk was 0.4%, 0.04 as a matter of fact. And the normal risk of seizures, even without a vaccine, febrile seizures, is 2.5%, or 2 to 5%. So when you're talking about this risk and putting it in context of reality, I think that's what we need our executives at those levels to really do. And I think people need to understand that. And so it's difficult sometimes to translate that to people, but that's really what the discussion was about. And so they changed the recommendations based on an increased risk of 0.01%. And so that is not what we would normally expect to see in terms of scientific rigor. They did take away some choice for some people who wanted to have their child vaccinated with the four vaccines in one, but it didn't have the same scientific rigor that we would expect in terms of making those recommendations. And so we just have to be more astute about how we make that known in order to try to quell what comes from that. The problem is that person is in a position of authority, and the authority over the organizations that shape how the dollars come out and what gets attached to those dollars is where it becomes difficult.
Yeah.
So applaud the honesty in terms of that action, appreciate that perspective. And I think many, even, I don't know if you guys know this, but I think it's called the Academy or the American Health Insurance Plans said, hey, we're going to take the ACIP recommendations that were in place September 1st before this new panel got in. Bodies, authorities, payers are saying, no, we're not going with the recommendations that are coming out because we know it saves us money and protects health by doing this other thing. So what you're starting to see is people saying, okay, you're not doing it, I'm going to do it. And fortunately, it came from states, it came from the insurers, it came from our specialty medical organizations in order to say, no, this is not right. And so that's what's going to need to happen more. But I will say that a lot of what you're hearing is really about community-based organizing or community organizing in terms of, I can say this, but he can't say this, and saying who, and so that's what we're going to have to do moving forward. We still need to do it before in the past. We'll still have to do it moving forward. We'll just have to do it more.
I know I often tell people, especially with what's available in social media and on the internet, if you really want to understand and know the truth or the science behind something, make sure you're on a .gov site. I now have to change that. And I do think that it's important for us to understand that there are areas, whether it's the NMA or some of the insurance companies who are saying, okay, look, we're going to go with the science on this.
Dean, just really quickly on that point, what's sad is this is a self-fulfilling prophecy, and this is only going to further exacerbate the lack of trust
The
in our
confusion.
institutions and
Yes.
government. So I am scared that it's going to be even harder to do what we did during COVID because nobody trusts us.
Right, right. It is difficult.
Yeah, but I don't engage in bad faith arguments ever with people. My daughter, anytime she has to clean her room, will start an argument in the kitchen. And I get that. That's what this is. But it doesn't stop me, and if anything, it propels me to pursue evidence that I can provide to policymakers, to government relations. We have a very robust exploration into the benefit of international medical graduates, who we've been able to establish, vastly increase uptake of preventive care. It's not just language congruity, there's something else, right? So my responsibility is to potentially allow others to have those arguments, genuine or disingenuous, whatever. I'm a scientist, and I'm going to continue to produce good science. That's the evidence we're going to be needing when it's the right time. And I'm very hopeful that that time is coming, and it's coming soon.
Any more questions? Well, I will ask for closing comments, and I'll share one to start. For me, a paradigm or a model when I'm trying to deal with something that's pretty complicated is the civil rights movement. And I look at it as one of the most successful changes in policy and practices in the United States. Certainly some of them very directly under threat. But the thing that I really appreciate growing up in Atlanta, watching very closely the discussions my parents were having, that people were having at church, is everybody was on the same page about the goal, but everybody was not on the same page about the strategy. And we are facing something that is coming at us in all different directions. And I do think we need people who go on the inside to try to figure out what's going on. We need people protesting on the outside. We need people operating on the DL. Then we need people who are like shouting it down. This is a really dastardly, complex context that we're operating in. So let's stay a collective and be kind to each other as we choose the strategy that we're going to use to try to respond and protect the health of our communities.
You want closing comments?
Closing comments. You guys have done such a great job. I'm so impressed.
One
with-
takeaway I will take from this, I'm excited to see the different organizations that we're coming from. And I do want to go back to Kedra, and I hope you go back to AltaMed. We clearly play a role in educating trainees, and we need to make sure that we're creating atmospheres, systems that can train the next set of health professionals. And so I really think that onus is more on us because we're very embedded in the community in ways that ivory towers may not be, the way the public health department can't be for all sorts of reasons. So this is the family that we need to make sure the trainees are in that laboratory and learning and getting to see those generations. And I hope they graduate and continue to work at AltaMed or Kedron. And hopefully they are folks that come from our community too, right? That would be great. So that is a dream, and you inspired me to believe that's actually a reality.
And that's what we're doing in the med school here. I don't want to get off on that tangent, but just worth note in our new medical school.
You just want to go last, huh? All right,
I
I will.
You want me to go? It's up to
No,
you.
I feel like I've said so much while I've been here, and I got so much out of this. I feel better. I think this is a challenging topic anytime, but it's not even what we're talking about, right? There's so much going on right now. We're talking about, complex risk modeling, which humans can't do very well. And that's what we're constantly negotiating. I remember during COVID when George Floyd was murdered, and I have to model in my head the risk of me going to a protest. And, not just for infections, but maybe getting beat down. And one of the professors here, Dr. Hafifa Sadiq, was organizing donations of medical supplies for people that were injured. Like, All this stuff, every single thing is such a complicated decision-making process. And so, given that there's this so muchness of it all, I hope that the folks watching this, and I think it's so cool that this is going to be available, online, you're not that far from people who care about you and are willing to have these conversations with you. And we literally need every single one of us. So in these areas that are a little bit more progressive and science aligned, where we have a very close network, just down the street, you're also part of that, even if you're in other states, other territories, because we have the internet and because we have these social networks. And so I just really hope that folks watching this feel less alone, feel better, know that it is a hard time, but it's our hard time, right? It's our dumpster fire.
Yeah.
And we're all kind of going through it, and I think that we'll be okay if we reflect on the fact that we're a big community, and again, it's a marathon.
It is.
I completely appreciate that, and one of the things that I hope is that people who are watching this and those of you in the room is that you feel like we've said something that has touched you, and that some of the experiences of the people around you we've heard and we've reflected that. I think those are the realities that we ran into, but those are the realities that we're all trying to resolve together, and we're trying to do it from our different vantage points. And sometimes we won't get it right the first time. The important part is that we try to learn from that and adjust. And as we continue to move forward, and especially, one of the things in terms of teaching about health and being a provider is to understand that sometimes we give information and advice that people can't understand, and sometimes we give information and advice that they cannot do. And I say that from the standpoint of what happens in a neighborhood. That's how I ended up in public health. I was giving advice to someone about exercise and diet, and they didn't have healthy food in their neighborhood. They didn't have the ability to take transportation to get to something, and they had 4 kids. And so I think as we give advice, we also have to acknowledge and understand the person we're giving advice to in order to help them deal with whatever they're dealing with, so that they can hear that advice in a way that is more positive and protective for them. And so that's really all that this ever is. Everything boils down to a dialogue. And what I said about community organizing, anybody who looks at this and says they're trying to do something dangerous and dastardly, understand that everybody does this all the time, and the folks in power are doing it as we speak. So it's just that we're doing what we need to do in order to protect ourselves and protect our communities. And I mean ourselves not in as me as an individual, but all of us in terms of our communities. And our communities are broader than what we think. And so thank you for being here, and appreciate you.
That's it, everybody. Thank you so much. Once again, Charles R. Drew, University of Medicine and Science, Dean Deborah, our panelists, Dr. Carlisle, thank you all. Thank you. Bye-bye.